Great. Welcome, everybody. Thank you for being here. I'm Diane Lipscomb. I'm the director of the Carney Institute for Brain Science, and it's my delight to give a very, very, very brief introduction. But mainly, just wanted to say this is a really special annual event. Many of you have been here for many, many, many years. It's 27th annual event, Mind and Brain Day, Research Day. So I just wanted to really emphasize a couple of quick things and then thank a few people for all of the organization that goes behind this really great day. First of all, I think that it's very difficult to know whether any conversation or any research finding is going to lead to some miraculous cure or treatment, but I think that we could say with 100% certainty that something that happens today and some discussion that happens today and some collaboration will, in fact, be really pivotal in creating some really dramatic discovery or treatment to make this world a better place. And I think that's the value of research, and that's the value of academic research. And many of you are here and you're just starting out and you're in a great field at a great time, despite all of the rumblings that are going on. There will always be research. There has to be research. And you're in a really amazing field. So thank you for being here. Have great conversations. I'm just going to say a quick thank you to I know all these people, I just want to leave anyone out. Audrey, you'll probably do the scientific introductions. But to really make sure that we thank the people who do a lot of the planning. Of course, Holly, Fatima, and Katie, thank you for everything you do every year for many of you. This is a tremendously difficult thing to organize. It's large, but it runs just brilliantly well because of their contributions, so thank you. And if I left someone out, Audrey will pick it up. And so I'm going to introduce Audrey Tucker, who's a fantastic chair of the Department of Psychiatry and Human Behavior, as you all well know. And just to say that this event has been jointly organized by the Institute and the department for many, many years. So, Audrey, thanks.
Okay, and I too am going to just give a very brief welcome to you all. This is one of our most exciting days of the year. It's such a great pleasure to come together with all of you, to see the joy on your faces, to see the excitement and curiosity as people learn from each other and share their work together. So yes, thank you so much to Fatima Alves, Katie Leisner, Holly Wilker, and also from Carney, Taylor Smalley and Wendy Lawton. I do want to acknowledge that these are very challenging times for science and academia, with some of our important work being defunded and targeted, and uncertainty and budget constraints in how we prepare for new changes. We are working together with Brown and with the health systems to navigate these challenges and support all of you, our faculty, trainees, and staff. We're working together, we're leaning into our strengths, our resilience, and our creativity to craft the best path forward together. And I'm just so happy that we have this opportunity today to come together, as Diane said, to remember what this is all about, to celebrate the incredibly important and valuable work that you're doing. And particularly today, this year, we're hearing from our very own faculty who are doing this cutting-edge work. So with that, I'm thrilled to introduce Professors Ben Greenberg and Dr. Linda Carpenter, who are going to tell us about the exciting program today.
Dr. Chirka. Oh, now I'm on. So it's really a great pleasure to be introducing a series of 6 speakers. Many of you may know them. Many of you probably do not. And I think we're hoping that at the end of this day, you'll have a better sense of all the great work out of an abundance of work that happens in our broader system. The way this is organized reflects some of the centers that we have in the Brown-affiliated system. So the first 2 speakers are going to be from the Butler Cobrey Center on Neuromodulation that I have the privilege of co-leading with Dr. Linda Carpenter to my left. We are often seen together on Zoom. And the next 2 are from the VA Center on Neurorestoration and Neurotechnology, where I am also the director with a number of people, most notably here, Noah Phillip, who leads our mental health restoration of function area. And the last is the Center on Central Nervous System Function, which is headed by Dr. Jerome Sains, which is based on the Brown campus. Linda?
All right, thank you. So the way this is going to work is it's going to be like speed presentations. Each speaker is going to have 10 to 12 minutes. You see a QR code up there, and we ask you to use the QR code to submit questions for the speakers. They're going to come into this system here, and we'll have just a little bit of time after each one to try to get a couple questions in. So you can submit your questions, and I believe when you put them in there, you can indicate which speaker they're for. For our speakers, we hope you'll do your best to stay on time. There will be some signs held up in front of you to help you keep on track. And then if you're really struggling, Ben and I will start to approach the podium and
We'll look uncomfortable.
give you the boot. All right. So that's how it goes. You want to start off with the
Yes.
first speaker?
Okay, the first speaker we're going to hear from is Dr. Nicole McLaughlin from Butler, and she is going to talk about actually a long history of work here, started by our former chair, Steve Rasmussen, on psychiatric neurosurgery here at Brown and Butler Hospital. Nicole.
Hi there. Thanks for having me, everybody. It's especially exciting because I've been coming to these for almost 20 years, so I'm excited to be up here on stage this time. So like Dr. Greenberg mentioned, I'm actually going to be talking about a long program that was started, as Dr. Greenberg mentioned, by Dr. Rasmussen, our prior chair, back in 1993. And this actually, this speaks to what Dr. Lipscomb was saying, that, this started actually as an experimental treatment and has transitioned really over to a clinical procedure now that is surrounded by research. So just to give a quick introduction, I'm going to talk a lot about OCD. These treatments that I'm going to talk about are for OCD, and OCD consists of obsessions, which are intrusive thoughts that cause distress or discomfort, sometimes fear, and then compulsions are responses to that distress, so behaviors that someone may do to reduce that distress. About 1 to 3% of the population have OCD. It's a leading cause of disability, but approximately 20% of those patients don't adequately respond to treatments, so things like behavior therapy, exposure and response prevention, and extensive medications, and they may end up coming over for psychiatric neurosurgery for OCD. And that includes deep brain stimulation, as well as lesion procedures, which I'm going to focus on here. So just a quick question. I'll go through this quickly because I don't have a ton of time. But who here knew that the TMS is FDA cleared for use in OCD? Just give a show of hands here. Okay, a fair number. Who also knew that DBS is also FDA cleared for OCD? Probably fewer there. And who is aware of lesion procedures for clinical treatment for OCD? And who knew that we do those here in Providence? So actually not, maybe a third to a half, so not too bad. So patients actually come to us for treatment from all over the world. They're severely impacted by symptoms, often unable to work. Some are completely homebound or institutionalized. And like I said, they've exhausted all medication and behavioral treatments. And many have tried at this point other treatments like ECT, TMS, ketamine. So they undergo a full screening here. Then cases are reviewed by a psychiatric neurosurgery committee who then determines if they're eligible for surgery. So the neurosurgery of OCD is pretty complex. You can see this is a quick slide that just shows all the circuits that are involved. And the surgeries that I talk about will target connectivity between deep areas and other cortical nodes in some of these circuits. So for example, thermal capsulotomy or anterior capsulotomy, gamma ventral capsulotomy, which I'll talk more about in a minute, and then also ventral capsule, ventral striatal, deep brain stimulation, all target these subcortical to cortical targets. So the first of these surgeries, thermocapsulotomy, was developed first in the late 1940s, long before any modern imaging was available. And then gamma ventral capsulotomy and DBS were based on thermocapsulotomy, but are better understood and are being refined through the combination of brain imaging and new brain anatomy research. So I'm going to talk about, like I mentioned, kind of how things have evolved over time and kind of what we've done empirically to see what's worked and what hasn't worked, and some of the more updated research that we're doing now. So in 1993, we started with single-shot gamma capsulotomy, and I'll talk more about these in a minute, which moved to an addition of another kind of what we call shot to expand the lesion. moved over to a full lesion and gamma capsulotomy, transitioned to another smaller lesion, and then in 2016 to a laser treatment, which we do now. I'm going to talk about all these a little bit more. So the first lesions that were done, we call this a single shot gamma knife, which means that there's basically a single lesion, and it was kind of what we see in the mid capsule here. I don't think you can see, oh, you can see my mouse there. And you see where the arrows are pointing. And this was based on some prior research that indicated that some of the pathways that go through the internal capsule were important for OCD symptoms. And so the internal capsule itself is not an important region for any specific thing, but it essentially carries all of these white matter pathways that come through the brainstem, into the thalamus, into the prefrontal cortex. And we know those pathways are important for treatment of OCD. So 15 patients at that time received what we call this single shot lesion. There were no significant improvements on the Y-box, anxiety, depression, or general functioning, and only 1 out of 15 of those patients actually responded to that treatment. So that means they had a greater than 35% reduction in their OCD symptoms. So they moved on, and they ended up expanding the lesion. And so they added what we call another shot to make this kind of a double shot, a second stage procedure. So 13 of 15 of those patients had a second stage procedure. About 40% of those responded to the treatment, meaning their OCD symptoms got significantly better, and another 15% were partial responders. So, and here, I'll go on to the next one, actually. So the next set of patients, 40 patients were actually treated with what we call a double shot procedure. So they ended up getting a lesion throughout the bottom third to half of the internal capsule. And that showed actually about, in this recent paper, about 70% were full responders, 23% were partial responders at 2 years. So this really was quite effective in a number of patients with, again, this very severe illness. So we carried on doing this for many, many years. It seemed to work well. We used the gamma knife, which is generally a non-invasive treatment that uses gamma radiation to create a lesion in the brain without having to put any equipment in the brain. And there was actually a randomized clinical trial done by some colleagues of ours in Brazil. And so this is a little tricky to do brain surgery in a randomized clinical trial, but the gamma knife basically looks like an MRI machine. So what they did was they built a chamber outside of that. So some patients who were getting active treatment actually went in the gamma knife, received active gamma knife treatment. The others in the sham group went into this chamber and made it look like they were getting the treatment. And it did show generally a significant difference between those who received active treatment. 3 out of 8 people responded, and 0 out of 8 responders to the sham treatment. And then those who ended up getting the sham treatment went back and got active treatment later. Many of them had a significant response to the active treatment. You can see here on this graph. So the double shot lesion seemed to work well in many patients. However, especially, it's a long story. We had a change in how the gamma knife, the model of the gamma knife, and we ended up having a few patients with cysts secondary to the gamma knife, including one who required neurosurgical intervention. So we ended up pausing the procedure for a period of time to figure out what was causing the cysts, which did seem to be related to a change in how the radiation was delivered. And there actually is a way in which it can be delivered in a safe way now that some places are doing. But we also started to think, was this double shot necessary? So patients, back at the beginning, about a year in, improved when that lower lesion was added in the internal capsule. So we said, and we had been thinking about this for a while, so we said, would that be enough? Maybe that smaller lesion at the base of the capsule would be enough, and we're less likely to generate side effects. So we went forward and we decided to try that smaller lesion, again, based on evidence from the past indicating that additional benefit was conveyed when we added that ventral shot. So like I mentioned here, so this is here the first type of lesion that was done that didn't work. And then another lesion was added below that. Seemed to work well in many patients. So we said, okay, well, let's just do this at the base of the capsule. We'll add this lesion here, see if it works. So between our site and a site in Brazil, we combined data. We did this on 11 patients. Nobody responded. So clearly that smaller lesion was not sufficient. So then we said, okay, well, now what? Clearly that smaller lesion didn't work. So what should we do next? So this was around 2016 or so, and a new technique came out, and this was called LIT, or laser interstitial thermal therapy, which actually allowed for MRI guidance of laser fibers to create a lesion. We decided to switch to that method. So again, the targets are the same. So we're doing the same methodology, or the same technique essentially as what we were doing before for gamma knife. We're lesioning the same area of the brain in the internal capsule because we know that worked quite well in many patients. But this technique actually allows us to take an MRI scan about every 6 seconds so we can see a thermal map of where the anticipated lesion will be, and then we can lesion there and see the lesion afterward. So when we started this, we are, from my understanding, I think the second site in the world to use this technique in OCD. And again, initial outcomes were consistent with the Gamma Knife, with about 50 to 60% of patients having good response. So when we did this, we took some of those initial patients that had that smaller lesion. We actually expanded the lesion for them to ultimately ablate the bottom third to half of the capsule. And then all new patients were again targeted to lesion the bottom third to half of the internal capsule. So at this point, we have follow-up data on about 22 patients. And right now, about 13 of those 22 patients are considered full responders, so about 60%. So again, OCD change of about greater than 35%. 2 of 22 of those patients are considered partial responders. So this means that our baseline score, OCD score, is a mean of about 32, which is kind of in the severe to extreme range of symptomatology, and a mean at last follow-up of 20. So there's an average Y box or OCD decrease of about 37%. And that, even though some patients are still symptomatic, can make a big difference in their quality of life. Some of our patients, as you see on this graph here, actually say that they have no symptoms at all. So it's very interesting because they'll say to me, oh, I see that, powder on the table. And I can look at it and say, well, a year ago, that would have really bothered me. But it's not doing anything now. It's not generating that distressed response that it did before, which is really interesting. And side effects are very low. We have patients who have a small amount of apathy in the first couple months after the procedure that seems to go away. And otherwise, we don't have significant side effects. So in terms of future targeting, so we've looked at some of the lesion size, location, and response in some of our prior Gamma Knife patients. So we had a sample size of 26, again, partially from some colleagues in Brazil, and then 12 from our patients here. Out of this sample, 18 or 70% were responders at follow-up, and these responders range from 7-month follow-up to 192 months post-op. And the mean Y box reduction for this group was about 50%. We went through and hand traced the lesions. And what we were looking at is we're looking actually at heat maps. So you can see this is actually just lesion frequency. So essentially this yellow here in the middle is the largest overlap in terms of lesions. And then as you go out further and further, this green is the least amount of overlap in terms of lesions. So you can see there's a significant variability in terms of lesion size in these patients. And everyone responds differently, and kind of their lesions are all different depending on kind of probably likely their brain reactivity. And what we are seeing is that we're actually seeing that those who have a greater OCD reduction are kind of in this blue here, and those with less OCD reduction are in this red to orange here. I'm going to keep going because we don't have a ton of time. So in terms of factors affecting response, there's certainly some clinical factors. So those who have had OCD longer, have poor premorbid functioning, are likely less likely to respond. Those who have only OCD as their primary issue and are functioning generally pretty well otherwise, potentially working, tend to do better. There's also potential differences between individual circuit variability. So with the lesion changes, are we missing the relevant fibers? So we're missing a specific location in a specific person. How much do we need to personalize this? Do we need to impact a certain number of fibers? So do we need to kind of have the lesion be a specific size to get a response? So next steps are continuing ablative procedures as well as deep brain stimulation, extending these findings into non-invasive treatments like TMS, determining predictors, and then individually adjusting lesion and stimulation sites for increased treatment response. All right.
All right, well, thank you very much. We'll kick off the questions here. For OCD, what's the treatment strategy in deciding to prescribe TMS versus DBS versus lesion surgery?
It's a good question. And right now, it's not a requirement for our program, but I would say for most patients, it makes sense to do TMS first. There's no drawback to doing it. Very few side effects. Insurance companies are starting to cover it. So it makes sense to do that before moving over to a more invasive procedure.
I have another question for you. Presumably, if the mechanism...
Let's finish. What about DBS versus a lesion procedure?
That's a good question. So I talked all about lesions here. We theoretically have the ability to do DBS here. We haven't done any patients recently. And as I mentioned, a lot of our patients are not local, so they're coming from all over the place. There's very few centers within the United States and the world who are capable of actually managing deep brain stimulation after someone has a procedure. So we can put in electrodes. That's not the difficult part. The problem is that making sure that there's someone actually that can follow a patient long-term who can continue programming that device. and managing their psychiatric symptoms, especially if they don't get better. And it's really hard to do that remotely.
Based on the presumed mechanism, Dr. McLaughlin, that you're describing of disrupting fibers, what do you anticipate, or maybe does your data show, is the long-term outcome? Does plasticity remodel and restore fibers that you've disrupted? Are they permanently?
Yeah, I think there's still a lot we don't know about, kind of the long-term effects. So we are one of the sites that actually continues following patients out to about 30 years. But there's very few of those because we don't do too many operations a year, and most sites actually don't follow patients that long. So it's hard to know exactly what happens long-term. What we think happens is that most patients, if they get better, they stay better. So it doesn't seem like most patients will relapse. We do think that there's probably a component that's related to, extinction, for example. So number one, their ability to tolerate things is better. So just like you might see in a patient who responds to medication and they may say, well, things don't bother me so much, right? So that's number one. They say, oh, well, this doesn't bother me so much, even though the thoughts are there. So there's some kind of affective response there. But then, and that seems to continue. So we continue saying, oh, you should keep doing behavioral therapy afterward because that likely strengthens that response and probably has some effect on kind of extinction of that initial response. But we don't typically see actually fibers coming back. But there's a lot we don't know still.
Fantastic. Thank you so much.
Yeah.
All right.
Thank you.
All right. Brian, next we've got Brian Kavanaugh. Yep, come on up, please. We got time ticking away. We want you to have as much time as possible. Brian's going to talk to us. Dr. Kavanaugh is at Bradley Hospital, and he's going to speak with us about evolution of, oh, no, he's not. He's going to speak with us about modulating the oscillatory dynamics underlying adolescent working memory with ITBS, with intermittent theta bursts.
Before Brian starts, there were a couple of other questions that made it into the question and answer. Dr. McLaughlin is not escaping yet. So the people who asked that should find her and please ask those questions. Go ahead.
Take it away, Dr. Kavanaugh.
Thank you, Ben and Linda. As a pediatric neuropsychologist at Bradley Hospital, my primary responsibilities involve the diagnosis and treatment guidance of neurodevelopmental disorders such as ADHD, neurocognitive deficits, and learning disorders. And as everyone here knows, ADHD is the most diagnosed mental health condition in children and adolescents. It presents more often than not with numerous other neuropsychiatric conditions. And despite fantastic treatments for ADHD, including medication and psychosocial interventions, the majority of cases persist into adulthood. Repetitive transcranial magnetic stimulation, or RTMS, is a safe, non-invasive approach to neuromodulation that has shown efficacy in numerous adult neuropsychiatric conditions, including adult depression, adult OCD, and adult PTSD. And excitingly, most recently, adolescent depression. Outside of adolescent depression, TMS remains quite unutilized in pediatric settings despite its known safety and tolerability profile. In fact, there has been just one sham-controlled trial in pediatric ADHD, and these null findings included 9 adolescents with ADHD published in 2012. So we wanted to know, does TMS have any utility in ADHD? And that's what we did. So we conducted an RCT from 2021 to 2024, double-blind, sham-controlled, testing TMS for ADHD. We enrolled 12 to 18-year-olds with a clinical diagnosis of ADHD and ongoing parent-reported symptoms. We used a crossover design in this trial. One of the reasons for this was the concern about enrollment. Brain stimulation is a new idea in pediatrics, so we were unsure how families would respond. So we wanted to maximize every individual's participation in the trial. So every individual completed one phase of 10 real TMS sessions and one phase of 10 fake TMS sessions, or sham. We targeted the left dorsolateral prefrontal cortex based on the prior literature showing TMS's potential utility in modulating working memory and cognitive control-related dynamics. We used a type of TMS called ITBS, or intermittent theta burst stimulation, which is shown to be non-inferior to the traditional 37-minute or 10 hertz TMS protocol and is probably the most widely utilized TMS parameter in research at this point. We did 10 sessions of 3 minutes per day for 80% motor threshold. So a relatively low dose of TMS. But remember, at this time, this has been going on for 3 years. So we conceptualized this study in 2020. It was initiated in 2021. And there remains essentially no literature on TMS for ADHD or ITBS in any pediatric samples. So out of abundance of caution, we took this approach to dosing. We use the NextStim Smart Focus. It's a neuronavigation approach, user-friendly, and has been very good to us. So we ended the end of 2024, and we're in the process of conducting formal analyses. So in total, across the 3 years, we randomized 29 fantastic adolescents with ADHD into our study. 82% of these adolescents completed all study procedures, specifically all 22 visits across 2 phases. Importantly, 4 people withdrew due to feasibility of getting to the clinic every day. This was really important to us. Probably the most important outcome of our study is that this is not just a healthy adult trying to get to the clinic every day with their own schedule. This is a parent trying to get their adolescent off the bus to Butler while managing their own work schedule, the schedule of all the other children in the home, and of course, navigating the bridge and the traffic of Rhode Island. So we believe we've addressed this, or we're working towards a better approach to feasibility with our accelerated protocol I'll describe to you later. Safety and tolerability was great, as was participant satisfaction. We had wonderful families in this study. We were very lucky. So we're in the process of conducting these formal analyses, and while we do that, we remained blind to treatment allocation. So as you can see here, we have a blue group and a red group. It's a crossover design, so every participant is represented in both groups. Blue may be active or sham, red may be active or sham. We don't know. But as you can see here, these linear models have a time by group interaction with a pairwise comparison after TMS showing a significant difference between the 2 groups. Now, we may unblind, and the direction of the effects may be what we expected, and that would be great. They may be in the direction we did not expect, and that would be great too. These effect sizes are 0.5 to 0.8. The biggest take-home for us is that these were not drastic, life-changing improvements in symptoms. Now that's, of course, a pretty lofty bar, but that really has become the expectation in TMS research, thanks in parts to the research done, particularly in adult depression, using accelerated protocols, where the right amount of parameters, the right targeting, et cetera, can lead to symptom reduction and even remittance in as little as 5 days, even more recently, as little as 1 day. So that remains our goal or expectation moving forward. And that's what we're really trying to move towards now. So TB2 was what we called our primary clinical trial. And again, that was 10 3-minute sessions for 6,000 total pulses. We received FDA clearance in the spring to start an open label accelerated protocol after participants had completed the primary study. So in the summer, we had 4 adolescents come back and complete 2 9-minute sessions per day for 5 days for a total of 18,000 total pulses. We had no adverse events and no withdrawals. We got FDA approval again to double that dose, to go from 5 days to 10 days. And we're finishing up our 4th participant in that accelerated protocol. And so far, we've had no adverse events and no withdrawals. And now the FDA is reviewing our request to increase that again to 54,000 pulses, so 3 times a day or 27 minutes per day for 10 days. As you can see in the figure, it's certainly apples to oranges, and there are a lot of confounding variables here, including open label status and the general placebo effect. What we see for our black bar is 20%-ish symptom change from our sham-controlled double-blind study. Then for our initial accelerated protocol in the summer, perhaps 20 to 30% symptom change against small cohorts. And more recently, with our highest protocol or pulse protocol, perhaps 40 to 60% symptom change. Now, this is really just to give you a sense of how we're conceptualizing our approach, this dose-response relationship to maximizing clinical response to TMS and getting as quickly as we can to an ADHD treatment. In addition to clinical outcomes, we're certainly interested in neural target engagement. So our neural target is oscillatory bursting patterns. We measure this with EEG during working memory demands. And many researchers before us have shown that there is an interaction or an inverse relationship between beta bursting and gamma bursting during working memory demands. We've been able to replicate and show that the degree of this relationship tracks very tightly with working memory status across visits. And we've further shown in our theta burst protocol that we're able to drive down this beta-gamma dynamic, essentially increasing beta bursting during working memory, and the degree to which we can do so correlates with working memory symptom improvement. So our next steps, in addition to continuing to test the safety of higher and higher doses of theta burst stimulation, our next scientific stop is going to be starting this summer when we test the differential effect of left DLPFC versus right pre-SMA, trying to develop specific targets for working memory and inhibitory control in adolescents who have ADHD and symptoms in both of these domains. So they'll be randomized to 3 times daily for 10 days in these differential targets. All the work I presented today is only because of my wonderful mentors, including Linda Carpenter, Tony Spirito, Stephanie Jones, Jen Barreto, Paul Corkin, of course, the fantastic clinical team, Eric Terrell, who runs the whole BNRF, or the Butler Neuromod Research Group, and of course, the great Meg Vigney, who is our research assistant who ran every participant in every session across these visits. Thank you very much.
Thanks, Brian. That was absolutely awesome. We have a number of good questions for you here. First one is that the person was wondering if the adolescents rate their own symptoms, and what was your participants, the adolescents, what was their involvement in the process for your outcomes?
Yeah, so this was what I described as parent-reported symptoms. We collect self-reports on emotional symptoms. So we use the PROMIS form to get anxiety, depression, anger symptoms. So those will be analyzed as well as part of our clinical trial. But sticking with the traditional ADHD approach to be most useful to the literature, we have focused on parent-reported symptoms as our outcome variable. But great question.
Okay, another one is this, the person says, kids are on stimulants for long periods of time, often to manage these symptoms. Would TMS replace prescription stimulants or work alongside with them? And maybe you could comment on the concurrent medications in your sample.
That's a great question. So we are not going to, TMS will not replace stimulants. I think the adult psychiatry world has done a fantastic job setting up for medication, psychotherapy options, and brain stimulation options. So they have 3 tools. In child psychiatry, we have 2 tools. So we want just to develop brain stimulation as a 3rd option for clinicians. And so there will never be a competition between medication and TMS, but rather a treatment allocation approach perhaps in the future. Participant A might be better with TMS, B might be better with stimulants. So that's something we want to do in the future.
One last question. There are more, but we won't get to them all. Does TMS improve working memory? And might it improve working memory irrespective of an ADHD diagnosis?
Yes, to both of those. So meta-analyses would show TMS outside of ADHD. This has only been in adults. The meta-analysis, TMS, including theta burst, across numerous adult neuropsychiatric conditions and healthy controls, medium to large effect sizes in working memory performance. It hasn't been done in adolescents, or excuse me, ADHD, so we don't know, but definitely independent of ADHD status.
All right, thank you. Again, for other questions, Brian's here. Okay, next, representing the VA Center for Neurorestoration and Neurotechnology. Although there are a lot of neuro in the titles of our centers, clearly, these are not mindless or brainless talks. Dr. Masha van Wout-Frank is going to talk about synergistic application of TDCS and virtual reality exposure for PTSD.
All right, well, thank you. A little bit. So I'm excited to be here today and present to you our approach as well as our data on the synergistic application of TDCS and VR exposure for PTSD, as Ben said. I also feel a little bit giddy to stand on this side of the podium for once after so many years of attending this Mind Brain Research Day. So I'm first going to show you my conflicts of interest slides, which I don't have, but this is a VA-funded study, and therefore our views are our own. As many of you know, post-traumatic stress disorder, PTSD, develops after experiencing or witnessing a traumatic event and is a major source of disability. Now, fortunately, treatments exist, and one of the most common evidence-based treatment is exposure therapy. Now, during exposure, patients repeatedly confront trauma memories in a safe environment, and this promotes the habituation as well as the formation of new memories, thoughts, and feelings that signal safety and which suppress the fear. However, around 50 to 60% of patients actually are unable to finish exposure therapy or are left with substantial residual symptoms following treatment. And the reason for these suboptimal outcomes are that the fear memory trace will never fully disappear. And this is usually a good thing because we want to fear what could harm us after all. But the core problem in PTSD is that the habituation during exposure or the recall of these safety memories is insufficient or fails over time. And this allows fear to persist or return. So our main question that we were really trying to address was, can we augment habituation for lasting fear suppression to improve therapeutic outcomes? Now, we know from both animal work and human studies that the ventromedial prefrontal cortex plays an important role in habituation and inhibits amygdala-based fear responses. We also know that the ventromedial prefrontal cortex in PTSD is hypoactive. So we decided to test whether transcranial direct current stimulation, or TDCS for short, because it's quite a mouthful, that can target the ventromedial prefrontal cortex could boost habituation. And what you really should know about TDCS is that it is a subthreshold modulatory technique that changes the likelihood of neuronal firing. So that also means that when you pair it with a therapeutic relevant process like exposure, it should have maximal effect. And which is why we apply TDCS during virtual reality exposure. And we opted for VR because it allows for highly immersive context that includes visual, auditory, haptic, and olfactory information, but at the same time can be highly standardized by presenting patients the same scenario multiple times, which allows maximal habituation. In addition, we can also control exactly when virtual reality events occur, which allowed us to collect event-related skin conductance responses to assess changes in emotional arousal as an objective indicator of habituation over time. So to first test if we could actually do this, we ran a pilot study in 12 participants, or 12 veterans with war zone-related PTSD from their deployment in Iraq and Afghanistan. Each participant received 6 sessions of standardized virtual reality exposure over the course of about 2 to 3 weeks. And half the sample, so 6, received active TDCS during that time, and the other half received sham, meaning we put the electrodes on the scalp, we pretended that it was sort of going, and then didn't actually apply any current. So here are the pilot data of this. I'm going to first show you the data on skin conductance reactivity here on the y-axis, and each of the 6 individual virtual reality sessions, 1 to 6, on the x-axis. So what you can see is that in the 6 participants who received active TDCS plus VR, they had a steeper reduction in skin conductance responses than those who received sham plus VR. And this indicates that the active stimulation augmented the habituation to these VR events over sessions. So now showing you the data on PTSD symptoms. self-reported symptoms here on the y-axis. And what you can see is that over time, from baseline to the end of the VR intervention, there's a significant reduction in PTSD symptom severity. But then something interesting happens when we followed up 1 month later. And I'll show this to you a little bit in a different way, so it becomes a little clearer that it is actually, oh, hold on, can you see my, yeah, you can see this, that it is only in the active TDCS group that the symptoms continue to go down post-intervention. And that is kind of unusual for psychiatric treatments, or any treatment really. Now, this was not actually significant between the groups, but if you start to get thank you cards from the spouses of your research participants, you really cannot help think that you're on the right track. So what we decided to do this whole thing again, now with a much larger sample and in a double-blind randomized manner. And by this time, the study also acquired a nickname TAVR, which stands for TDCS Augmented Virtual Reality. So here's a summary of our concert diagram. The only thing I really want to point out here is that we have really high completion rates of 92 and 96%, much higher than what you typically see in prolonged exposure interventions. Again, showing you data on skin conductance, reactivity to the virtual reality event, and you can clearly see that this looked very similar to what we found in those 12 first individuals. Plotting that next to each other, you can see that the active TDCS combined with virtual reality augmented the habituation over the course of these sessions. Again, showing you data on PTSD symptom severity. Now we use the 1 month outcome time point as our primary outcome based on the data what we found in the pilot study. And what you see is that at that time point, groups actually significantly differ at this point, with a large effect size actually. And that effect size carried over into 3 months follow-up, but this is no longer significant. We had a lot of dropout from 1 to 3 months. This was, let's call it the COVID effect. This ran during that time. But plotting this next to the pilot data, you can see how similar it is. And to show you this again differently, you can see quite how similar. It's really during that follow-up intervention time period where we see the biggest effect of the intervention. And that really suggested to us that TDCS augmented the recall of safety memories that were acquired during the intervention. But if habituation is indeed important for clinical outcomes, and both are augmented by TDCS, we would also like to see that veterans who habituate more during active TDCS plus virtual reality, here on the x-axis, also report a greater reduction in PTSD symptoms on the y-axis. And this is exactly what we found. And this association is not significant in sham group. Now, we have been working on this study forever. So we also have data on the on psychiatric relapse 1 year following the last VR session. This was based on medical record review. I will not go into the quite details of what relapse meant, but all I want to say, out of the 54 individuals that completed this study, 17 relapsed, 13 of those, let's not exaggerate, 13 of those were in the sham group, and 4 of those were in the active TDCS group. And when you look at the survival curves, you can clearly see the benefit of active TDCS over sham. In fact, any relapse that occurred in the active group happened within the first 2 months. That was still during our follow-up time periods. Medication changes also favored the active TDCS group, with a greater percentage of individuals that decreased versus increased their medication compared to the sham group. Now, then the last part, I haven't seen a sign yet, so that's good. So the last part I wanted to mention is that we're also looking into the potential mechanism of action of TDCS within this study, where we took on 44 individuals, MRI scans that were collected as part of the study, and modeled the electrical current flow in the brain based on the TDCS montage that we used. And one question that we really hoping to answer was, can we find regions within the brain that we know are important for PTSD, for therapeutic response, and can these predict how well people habituate or how much reduction in symptoms you may see? So here is some of that data. One of the regions that we modeled was the right insula, given the importance of salience detection and interception as well. And what you really clearly see here that in the active TDCS group, the greater the amount of voltage or current that we can get into the insula, the greater habituation we see in these individuals. And this is, of course, significant in the active group, but not in the sham group. Makes sense. We never actually put any current in the sham group, so that is a nice control. Now, interestingly, we also found this in the right hippocampus and bilateral amygdala, but not in the ventral medial prefrontal cortex, which was actually our target region. So that was interesting. Now, the amount of current actually in the right insula also correlates significantly with the degree of symptom improvement that you see over the course of the intervention. Again, in the active group, but not in the sham group. So really, the main takeaway that I want to end with is that, yes, this TDCS and VR was very feasible, acceptable, had great clinical outcomes, but what the exact underlying neural mechanism is may not be only ventromedial prefrontal cortex-based top-down modulation, but that we need to look more in these regions important for saliency. And with that, I want to thank and highlight the wonderful team of colleagues, research staff, collaborators, as well as the veterans who provided their time and willingness to participate in these studies. Thank you.
We've had a few questions come in. How does the efficacy of VR exposure by itself compare with traditional prolonged exposure?
Yeah, that is a good question. So I think when virtual reality exposure therapy, or VRED, was first came out, the hope was really that it would be better. It's not. It's very comparable in terms of efficacy as prolonged exposure, with that caveat that some veterans or anybody with PTSD cannot necessarily tolerate the talking about their trauma. So for those folks, the virtual reality context is actually really helpful to engage them with the traumatic context and therefore go through therapy.
And I can also add that these devices, the VR devices by themselves, have been distributed widely across VAs.
Yes.
Next question. Were there other kinds of trauma besides combat trauma in the sample you studied?
Yeah, so what you often see is that once something bad happened, it sort of happens again. A lot of the individuals in these types of studies also have childhood trauma and multiple trauma. So everybody who was included did have traumatic experience with experience during their deployments. But it is not necessarily what they themselves see as the most important trauma in their lives.
And in a 10-second follow-up to that, can you just say, how would customizing, and do you believe customizing the VR experience would change or augment, or does it matter?
Yeah, so that is also a good question. So there's a couple of thoughts of that. We on purpose made it such that it would be applicable to most. So all the VR content that we showed were things that everybody had seen. So it wasn't individually customized. And the reason for that is that we felt that it would still elicit the trauma memory, but not necessarily go to the extremely hard parts, because what we wanted to do was sort of retrain the brain to deal with the memories without necessarily making it so difficult that people would not do the treatment.
Okay, there is one last one. Do you think this might be replicable in other populations with PTSD?
Yes.
Okay. Great. Okay. Next up, also representing the VA Center for Neurorestoration is Amanda Arulpragasm, who is going to give a talk on Low-intensity focused ultrasound, a newer neuromodulation technology, early experiences with non-invasive deep brain stimulation. Thank you.
Wonderful. Thanks, everyone. Happy to be here. So I'm excited to talk about our early work using this novel intervention in depression and anxiety. So depression, anxiety, PTSD, these are all debilitating disorders that can greatly impair our patients' lives. And standard treatments for these disorders include pharmacotherapy and psychotherapy. And while these interventions are efficacious, they're also oftentimes associated with difficulties with adherence, side effects, and only moderate effect sizes, with a lot of folks deemed non-responders even after appropriate and adequate courses of treatment. So the lack of more effective treatments has really signaled the need for the development of novel interventions, especially in these treatment-resistant populations. Non-invasive brain stimulation, we've heard a little bit about that from some of our other speakers today, but it's a rapidly expanding area of psychiatric research and practice, really aimed to address this need and fill this gap. And the two most popular types of non-invasive brain stim include transcranial electrical stimulation and transcranial magnetic stimulation. Both of these have shown promise for treating psychiatric illnesses, but they're limited by their mechanism of action. So they both rely on electromagnetism, which means that they produce diffuse electrical fields that decay exponentially as a function of cortical depth. So they're really limited with targeting more cortical regions. They lack the spatial precision of invasive techniques, which might limit their therapeutic utility. And again, because we're limited only to target these cortical areas, they rely on indirect polysynaptic downstream modulation. But what if there was a way that we could target deeper structures without that depth focality trade-off? And that's where focused ultrasound comes in and is a really exciting and promising new technique. So sound is a pressure wave, and the thought is that pressure waves are interacting with brain tissue. And this can be applied at high intensities or low intensities. At high intensities, there's actually really rapid heating of brain tissue, greater than 55 degrees Celsius, which causes coagulative necrosis, so actual cell death. At lower intensities, neural mechanisms are a little bit unclear. There's some thoughts of thermal effects, mechanical effects. Not a lot of data to suggest that thermal effects is really what's happening. It doesn't seem like it's increasing temperature too much. So mechanical is kind of the leading hypothesis there. But at these lower intensities, more akin to what's found in diagnostic ultrasound, it's thought to induce neuromodulation. And then there's also been work kind of coupling low intensities with microbubble contrast to induce blood-brain barrier opening. I'm going to be focusing more on the lower intensities, so more in the neuromodulation space today. So no current technology is able to non-invasively and focally modulate deep brain regions. If you look here, we're looking at some of these electrical field models in TMS, TDCS, as Masha just mentioned, which is a form of transcranial electrical stimulation, and then focused ultrasound. And the best case scenario that we've had thus far has been centimeter scale for TMS. But if you're looking at that ultrasound image, you can barely actually even see this electrical field. It's this little dot right here. And because these ultrasound beams can be focused, we can actually get to millimeter precision, which is really exciting since this is a non-invasive technology. And so Noah, Phillip, and I, we actually published this little hot topics just talking about the promise of this approach for deep, non-invasive deep brain stimulation, if anyone's interested in learning a little bit more there. So this technique has been started to be used in psychiatric populations. I'm going to highlight just a couple of recent studies briefly. So this one, they're using focused ultrasound to target the bilateral nucleus accumbens in substance use disorder. And in this particular experiment, we're focusing on just one person, a 43-year-old man who had severe opioid, stimulant, nicotine, and cannabis use disorder. They did 10 minutes of single-blind focused ultrasound. This is out of West Virginia. And this participant was receiving residential substance use disorder treatment at the time of study enrollment, had a 13-year history of intravenous heroin and methamphetamine use, 30-year history of using cannabis, and near daily use of these substances. And as you can see, if you look at their self-reported craving ratings, there's a significant decrease in craving reported for all three of these substances following active ultrasound compared to sham. And what's also exciting is that, again, only 10 minutes was the dose here. that up to 90 days later, there's still a negative urine tox screen for these substances of choice. So this is pretty exciting. Again, it's one person, but speaks to the potential durability of effect of just 10 minutes. This next study targeted the subcallosal cingulate in depression. And they were looking, I know this is like a little bit of a Hannibal Lecter scary mask, so we're not doing that at our place. But they're doing 40 minutes of real or sham stimulation. They had 22 participants in this study. And what you can see on this graph, so they're looking at fMRI or bold signal. And when the ultrasound device is turned on, which is marked by this yellow bar, you see that bold activity in their area of interest decreases. And this is pretty striking here, that we're seeing this target-specific decrease as a function of stimulation. There is some individual variability, but on average, they're showing a decreased activation in their target site. They were also collecting mood and depression scores, and they found that these scores improved more with real compared to sham stimulation, but this was only really trend level in their intent to treat sample. They did notably have 2 patients who had acute depression worsening about 24 to 72 hours after sonication. But this, again, just speaks to potential neural effects and changes related to sonication. So the study that we've been conducting, and this is led by Noah Phillip at CFNN, is a first-in-human clinical trial using focused ultrasound in depression and anxiety targeting the amygdala. And there's 3 aims of this study. The first is to evaluate safety and tolerability. And we're looking at safety as more than just physical injury. We have a huge team of psychiatrists, neurologists, neuroradiologists, neuropsychologists, and more who are really working to cover our bases to make sure that we capture any and all safety signals to potentially de-risk this for other folks. We also want to examine whether MRI-guided focused ultrasound can modulate the amygdala. And there's a lot of research that's suggesting a suppressive effect of focused ultrasound. I don't know it's that kind of simple, but due to that and the fact that oftentimes the amygdala is hyperactive in depression and anxiety, we thought that'd be a good place to start and see if we can actually show some suppressive effects of this technique. And then lastly, we wanted to develop simultaneous focused ultrasound and fMRI. And this is a really exciting thing to have contextual manipulation while the brain's being stimulated, something that we don't really measure as much in the non-invasive brainstem space. So I want to show you a little bit what our setup looks like. This is our transducer. Looks a little bit like a hockey puck. This is a past research staff member who volunteered for this beautiful photo shoot. And you can see that the transducer is affixed in a holder that's then connected to these head straps that go around the patient's head. The transducer we use, we have different focal lengths of the transducer. The one that we've been using in the study has been the 65 millimeter transducer. It has a sonication zone with a focal peak depth of about 60 millimeters. And you can see here this little red cigar is our sonication zone. So it's about 30 millimeters long. So not tiny, but better than what we've seen before, but only 4 millimeters wide. So that part is really exciting. And this is a single element transducer. A lot of folks are developing multi-steering element transducers that can actually get this focal zone to be a bit smaller. Our study design, so we had a single blind controlled crossover design. We had folks undergo MRI procedures, and they were randomized to receive focused ultrasound to the right amygdala, which was our target, or left somatosensory cortex, which is our active control. Again, they're receiving ultrasound while in the MRI scanner. Then, at least a week later, they received sonication to the other region, whether, again, amygdala or S1. And during all of this, there were regular clinical and safety assessments throughout. You can see our device settings down here. Again, for all of these folks, we were using that 65 millimeter transducer. Our fundamental frequency is 650 kilohertz, 10 hertz PRF, 5% duty cycle. They had 2 10-minute administrations of ultrasound, 30 seconds on, 30 seconds off. And our intensity levels are within that diagnostic ultrasound safety range. Folks go into the scanner, again, with that transducer affixed to their head, and we're able to do MRI targeting in real time. So looking at structural scans, the transducer we have has these built-in fiducials, which you can kind of see as these bright spots on the MRI scan. We line up our markers to, first of all, measure the focal length to make sure that the transducer size we're using is the correct one. So we do this all in real time and verify it offline. And we also just make sure that we're lining things up with our target area. So we're doing line of sight targeting, again, in real time, MRI guided. We use anatomical atlases also just to make sure we're in the right spot. We're now in the process of doing some retrospective modeling, doing acoustic modeling to verify how good our line of sight targeting is when we take into account curvature of the skull, other types of features. So more on that later. So our study is ongoing. The first phase of 10 participants is complete. We're in the second phase right now. No serious adverse events yet. Non-zero side effect profile, though, that does seem to relate more to amygdala sonication compared to S1 sonication. We have unblinded safety assessments and rater-blind clinical outcomes, and we're starting to investigate target specificity, looking at ASL, which is a measure of cerebral blood flow, and BOLD. This is just a list of our most common side effects. You can see headaches, sleep disturbances, cognitive attention problems, mild changes in emotions or feelings are the most common. It is notable to say we had one participant who did have some acute worsening of psychiatric symptoms that resolved by the end of study procedures. So I want to highlight more this dark line, which are self-reported symptoms of depression. And you can see that there was a significant worsening of depression symptoms immediately following amygdala sonication. We didn't have this person go to get the other sonication. We put them in an extended follow-up phase. And then over time, this did resolve. Interestingly, this person also had extreme changes in perfusion of the target area that also resolved at the end of that follow-up phase. Some preliminary cerebral blood flow findings. Directionality has been variable. Some people are showing increased cerebral blood flow. Other folks are showing decreased cerebral blood flow. But if we look at the absolute change, we see greater change in our targeted area, so the right amygdala, following amygdala sonication. This is greater than our control site of the left somatosensory cortex. But what's most striking is if we look at the spatially adjacent right hippocampal head, we also see that there's increased change in the amygdala compared to that area. So some preliminary evidence of the specificity of effect, which is quite exciting. So stay tuned. We're anticipating publishing these findings, our neural findings, clinical and safety this summer for this first cohort. So first, to our knowledge, active controlled design. And we have some additional funded projects exploring sonicating the amygdala and PTSD, as well as sonicating the dorsal medial prefrontal cortex to target anhedonia and depression. So if you're interested in this or want to learn more about focused ultrasound, please don't hesitate to reach out. We're always looking for collaboration opportunities and really excited to talk to folks. So with that, I want to thank our wonderful center, our funding and support, and all of our veterans who have donated their time. Thank you.
We have some questions. Does sonication of somatosensory cortex elicit sensation?
Yeah, so that's a really great question. So we haven't seen that much of that in this particular study. We have had one person who reported a little bit of a feeling of like unrealness that could have been potentially related to that. But there's a few things. So when we're targeting the amygdala, we have our transducer located over the temporal window. So this is the part of your skull where the bone is very thin. And we did that on purpose. We wanted to allow for minimal amount of aberration or attenuation that the skull might cause. Our S1 target, we're going kind of back here where the skull is a lot thicker. So it's very possible that not as much energy is actually making it past the skull and into our S1 target. That's something we're also going to be confirming with our acoustic modeling.
Can you add to that by saying, why did you choose S1 for the control?
Yeah, so that's a great question. I think we wanted to use a particular area that was less commonly implicated in psychiatric illness, and we also wanted to pick an area that was kind of located, again, under harder, thicker bone, with the thought that less energy or maybe even no energy would make it past the skull and actually cause changes in that area.
I can add to that and then ask the last question, which is there is some thought that there may be an acoustic artifact of focused ultrasound that might relate to some of the effects, and this would control for that.
Correct.
And what about long-term risks to memory when the amygdala is the target?
When the amygdala is the target, you said?
Yeah.
Yeah, so we haven't seen anything that would be kind of problematic for that. So we do, as part of our safety team, we have a bunch of different neuropsychological assessments and batteries that are assessing working memory, delayed recall, immediate memory, and all of those different types of domains. And we're not seeing anything that is alarming or persistent across our study procedures there. So nothing that we're concerned about at this moment, but great question.
Okay, that's it. Thank you.
Thanks.
Okay. All right. Thank you so much. It was fantastic. Next up is, Okay. Next up, we have Matt Nasser, who is going to speak to us about neural representations for flexible learning. Matt's representing Jerome's COBRI for CNS function. Thanks very much. Take it away, Matt.
Great. Thank you. I slightly amended my title since sending it in to make it more specific. So I'm going to talk about grid representations for efficient transfer learning. Question mark, and that question mark may be important. So the first thing I should say is this work wasn't actually done by me. It's done by collaborators and folks in my lab. Avi Vaidya and Linda Yu ran the overall study with the support of Aya Akhmetsova and Sienna Brunsma. So the question we set out to ask is, I feel after seeing the last 4 talks, maybe not as good-hearted as all of these clinical "can we cure something" questions. We just wanted to know how the brain did something, which is how it transfers information from one context to another. And the sort of motivating problem is this: I go to my grocery store, I learn how to navigate the grocery store to find all the stuff that I need. Then on vacation, I also need to go to the grocery store to get all the same stuff. How do I then take the knowledge I've collected before in a grocery store in the US and apply it to solve this new problem in France in this case? We might imagine maybe I can, sort of bootstrap some of the knowledge I collected at my home grocery store because there are these certain common elements to all grocery stores, right? They all have an entrance, they all have a produce section, they have dairy. And you could imagine that maybe there's some way of transforming the representation of the thing that I know into something that could be helpful for this sort of novel environment. And the basic idea here is that maybe I have formed some abstract cognitive map, and that the brain does this and allows us to use the information we collected in one environment to solve a problem in another. And the question would be, what sort of neural substrate might allow for that? So one idea is that the brain has grid representations. And so the grid cells were discovered in the entorhinal cortex and are characterized by sort of periodic firing across two-dimensional space as sort of rodents navigate around these little arenas. And the peak firing of grid cells seems to fall on these vertices of hexagonal lattices, and it sort of looks like a grid, and we call them grid cells. If you have a bunch of these cells with different spatial frequencies, you can use that population code to know exactly where you are, which makes it a useful sort of representation for forming a cognitive map. These things are not just in rodents. You also can record them in OR patients that are navigating, both in entorhinal cortex and in prefrontal cortex. And recently, folks have developed methods to identify grid representations in fMRI data. And the sort of logic here, if you can see my cursor, yeah, cool. So is that, well, if we expect a representation like this grid, then we should expect peak activity when I am moving along some trajectory. And we should also expect if I move 60 degrees rotated to that trajectory, so at a 60-degree angle, clockwise from where I was going before, that I should be at another peak. And that means we can look for a grid representation just by looking for a sinusoidal activation of bold response as a function of the angle that I'm moving through the environment, where the peaks are separated by 60 degrees. So when you do this, you can also find representations in similar brain areas, entorhinal cortex and prefrontal cortex. And this finding sort of led to a number of follow-up studies where, we see that we can find these representations for navigation of a physical space, but it turns out we can also find them same representations for navigation of a more cognitive space, actually of a visual space, or even of an olfactory space. And this is sort of like raised the question, maybe this sort of representation might serve as a general substrate for a cognitive map. One last piece of background which is useful for this purpose is that these things also tend to rotate. So if we record from grid cells and entorhinal cortex in two different environments, we'll see that if we rotate the firing of all of the neurons in environment 2, we can find some rotation at which we then get back a relationship to environment 1, as if the entire grid code just rotated as we moved from one environment to the other. And so that sort of like poses the question, can we solve this grocery store problem by learning onto a grid representation that then rotates into whatever setting best serves our needs in the future. All right, and so the way that we can test this is we designed a task that has, participants are asked to move this colored shield to a target location to block alien attacks, I guess. And so they move the shield, and there's some target location for purple, and they see the actual missile attack somewhere on the screen. Then the participant will see a different colored shield and then have to move that shield to block the next missile strike. And each target location differs by color. So they have to move to a different location. They see, in this case, that they caught it, and they move on to the next trial. So the participants would see 5 different shield colors through the training period, and each of those shield colors is associated with a different attack location. And after repeatedly seeing all of these trial types many times, at some point we would have a state change where now the target locations for each color changed in a very specific way. So they all got rotated 90 degrees. And the prediction would be, well, if grid codes are just static and representing physical space, then we should see a common grid code from before to after the rotation. But if it's this sort of cognitive grid code that could transfer knowledge from one situation to another, we should see the thing rotate. And that would allow for performance where the participants can immediately know what to do in the new situation. So we had people perform this basic behavioral task in the lab. Then we had them perform the same task in the scanner, but added in some novel colors, test how well they can generalize. And then in a follow-up behavioral study, we asked them to do the same task, except had them do novel rotations that they had never seen before. The participants learned across the first session to, place their shield wisely, I guess, and improve their performance. They continued to learn across the second session. But the key thing that we wanted to measure is what happened on these trials right after a rotation, which is just as I go into the French grocery store, do I know what to do? We know that the participant is going to sort of fail on the first color that they see because that's the only cue that they have to tell them, oh, things have rotated. So what we're going to do is plot the performance on that first color they see against the performance for the next 4 colors, where they haven't seen them yet in this rotation. But if they are able to transfer their knowledge, then they should have better performance than in the other case. What we can see is that across the board, people tend to do this, although there's a lot of heterogeneity, with some individuals able to do it better than others. So we can follow up on that with a couple other easy behavioral things. One, we can add in a new color and test it in a rotation that the participant has never seen it in. That's a little harder of a test, but people still pass that. People are able to generalize there pretty well. We can also add in this novel rotation condition. So we rotate things to some angle that people have never seen before. They do poorly on the first color they see in that rotation, but immediately for the next 4 colors, they're able to figure out where things should go. So people are able to actually transfer their knowledge in this task and show us that they're transferring their knowledge. And so the question is, how did the brain do it? And what we're going to do is look for grid representations. And we're going to follow sort of a set of rules that previous papers have laid out for doing this. So we're going to try to identify areas with six-fold modulation of the bold signal, check the reliability of those areas across different sets of data, and then test for specificity. And I'm going to show our results next to those of another study that found cognitive grid representations, just because I think that it identifies that we're pulling up the same things that previous studies have found in this sort of representation, which includes PCC and VMPFC, as well as temporal parietal junction and parietal cortex. The one thing that we don't see, which is also the motivation for the study, was entorhinal cortex. So we actually don't see entorhinal cortex in our study, whereas previous work had found that. Nonetheless, we have 5 different brain regions where we can see something like a grid representation, and we can ask, well, we've got these 2 states. Does the representation reliably maintain one grid code from state 1 to state 2? And we can imagine it doing so in 2 different ways. So one way is if it represents physical space, then the measurement that we make in state 0 should translate directly into what we expect in state 1. And so this should lead to a positive coefficient for this reliability analysis. But if the grid is actually rotating to translate the knowledge that I have about one situation to its application in another situation, then everything should be shifted for state 1 by 90 degrees. And that leads to this sort of completely anti-correlated prediction, where I would expect actually to see a negative coefficient in this case. So we can look for either cognitive or spatial grids and test whether individuals sort of fall in one direction or another. And we can test that separately for each of the brain regions. And what we see is actually in the first 4 areas, no systematic consistency across the 2 states. However, in the parietal cortex, we see a clear preference for sign flipping. So it's a cognitive representation, as if the grid rotated into the space appropriate for the state 1. So if we can ask, okay, well, we have that. Is it specific to a grid representation? It does indeed show the 6-fold symmetry and doesn't show other forms of symmetry, which means it's specific. And we can ask, does it underlie behavior? Oh, am I?
Yep. How can you wrap up?
It does not underlie behavior. And the reason why it does not underlie behavior is because it shifts too slowly. So if we look at a single trial and we look at how the grid code changes over time, what we can see is that the code is not consistent for the first 5 trials, where the subject is actually transferring, but it rapidly shifts after that. All right, I'm going to skip this part and say thank you to the folks who did the work. Happy to answer questions.
Okay, great. 2 questions. What do you make of the fact that entorhinal cortex did not show up?
Yeah, I mean, it's pretty interesting. So if we had, I think if we had really pushed for the entorhinal cortex, I think we would have done this in a virtual reality setup. So had people egocentrically navigating through the, grocery store or the, planet. But the, I showed the results side by side by this Contanescu paper, where they certainly did not have virtual reality setup. It wasn't even a spatial navigation problem. And they did some extreme instructions where they had people imagine walking through a space of stretchy birds. So it's possible that those instructions elicited the use of more pure egocentric navigation systems that we didn't get. But I'm not very confident in that answer.
Okay. All right. Well, no, you resorted to hand waving at the end. The thoughts on the similarity of your regions to the default mode network. That's something I also wondered about, especially the anterior cingulate and posterior cingulate.
Yeah, that's a great question. I don't know. So I guess we do see the parietal, IPS, intraparietal sulcus, which was the one part of the grid code which seemed to systematically rotate in a way that could, in principle, transfer knowledge. That's definitely not part of the typical default mode network, but definitely VMPFC and PCC are. I'm not sure. I mean,
that's good enough. It's good enough. All right. Thank you again.
Thank you. All right.
All right.
That's great. All right. Final for our last speaker today. I'm excited to introduce Rike Petchner, who's going to speak on mechanistic insights into chronic pain. Take it away, Rike.
All right. Again, a switching gear and goes back to disorder now. And I just want you to think back the last couple of years and how much your life has changed due to the large progression that we had in AI. And it's really been affecting every single person in this room in their own specific ways. But interestingly enough, it's also affecting healthcare. And just to give you one data point on how much it is affecting healthcare, the amount of healthcare data generated doubles every 73 days. So that's less than 2 months. And one of the things that should concern us is that a lot of that data is actually owned by private companies, and there's a lot that has been done with the data that's not part of the scientific community. So I was approached by the former director of the NIMH, Joshua Gordon, to think about what that actually means in terms of our research that we do in the context of neuroscience, and specifically how it could impact the way we're thinking about mental health. And specifically, we were thinking about how can these developments, both on the side of this increased amount of data, but also the developments over the past couple of years, really improve our understanding, our prognosis, and our treatment of mental illnesses. And that's really what I want you to think about in the bigger picture when I then go into the specific examples that we're taking. And there have been two big developments. One I already mentioned, which is an increase in data, but there's also several developments on methods. We heard great talks on methods to change brain activity, but there's also a lot development of methods that are computational methods. How can we analyze this data? We've seen LLMs really progress a lot, so how could that actually enter the field and help us improve outcomes? And so I want to give one example, which is data-driven approaches in mental illness. And to give you an example of what is meant by a data-driven approach, take a very simple example where you have a lot of patients. And then often what you do is you gather data that can be brain imaging data, it could be EEG, could be behavior, could be smartphone data. And then what's often done is you train a model and you basically know, for instance, that some individuals in this group are going to respond to treatment A and others are not. And what you would like to do is really differentiate between who is going to be a responder and who's not. And this is where you often see the application of machine learning. In this case, that's a classification problem where you later on want to be able to predict who's a responder and who's not a responder based on the data you've acquired. One of the big missing parts in the current scientific setting and often in the publications that I worry about is that that's not enough. What you actually should do next, if you have a model that predicts something, is you should test it on unseen patients and see if it actually generalizes. And a lot of the big findings have been proven not to generalize across different data sets. So that's one of the big issues that we've been seeing in the field lately that I think we can change by really making sure that this is part of the actual methodology we use. But once you have that, you can actually apply this to the patient population and think about treatment allocation. Now, there's one subset of these problems that I'm particularly interested in for several reasons, and that is prognostic validity. So what do I mean by that? It means that you want to not only say something about a different group of patients, but you want to say something about an individual and how that individual is progressing over time, and whether this specific person is, for instance, going to respond to a treatment or not. And this is referred to as kind of prognostic validity, but it's also the holy grail of what everybody's talking about right now, which is precision medicine. So in order to do that, the idea was originally we could solve that with big data. And when people talk about big data, they always mean getting a lot of data, no matter what kind of data. And I would argue that that's actually not the right approach, because if you really wanted to say something about prognostic validity, you need a specific kind of big data, which are deep and wide data. So what I mean by that is that deep data means you have more information about the individual and you ideally follow them up over time. And then wide data means you have a large sample of the population that you actually can follow. So what kind of data is that? In the scientific world, it means that we actually need longitudinal data. And there is a big issue with that. If you think about, for instance, classical grant funding, which lasts 3 to 5 years, is that it's very hard to get these kinds of data over longer periods of time. It's very expensive too. And there isn't that much incentive because it usually means your publication comes at the very end of that. So there's also not much product out of it in terms of a scientific research perspective. But I think this is where you see the best outcomes for patients. So how does it look like if you're actually acquiring longitudinal data? And I'll show you different examples of short and long time scales. And here's the first example for which, where you can basically use a prognostic prediction in the context of chronic pain. So a little bit about chronic pain. It means that it's pain that has been persisting for more than 3 to 6 months. Currently, about 20% of the population in the US is actually suffering from chronic pain. That is a lot of people in this country. And there's bad news for a lot of those patients because no matter what you try in terms of peripheral interventions, doesn't matter if it's surgery or if you're burning the nerve endings, more than 40% actually will not respond to the treatment. And that's why you see many, many patients being in pain for over a decade without getting appropriate relief. Part of the problem and why we're really interested in this is because there is a strong brain-based component to the persistency of pain that has been often ignored. And I think these networks are highly relevant for us. And there's also a high comorbidity with depression. About 65% actually suffer from a comorbid depression. And again, what's clinically important here is that oftentimes the depression remains untreated when people are seen with pain because they're no longer even asked for mood or depressive symptoms. So here's an example where we wanted to know, can we predict if someone is going to respond to a treatment? In this case, it's an injection into their lower back. It's a local anesthetic. This is a sample size of 252 patients who were asked right prior about certain symptoms and their beliefs, and then we followed them up after 2 weeks, and that's usually when you start to see the effects of an epidural injection. And we could predict who will respond and who doesn't with a very high accuracy on a 10-point pain scale using a machine learning model. And basically the key predictor, which was very interesting to us, was whether you expected to get any relief prior to even receiving the treatment in the first place. So a lot of you will be thinking, well, that's a placebo response right there. But it's actually interesting because it's relevant for treatment. If you believe that you will have better outcomes and you actually end up having a better outcome, that's an angle that actually could be relevant for care. So we actually followed up with a randomized controlled clinical trial where people get a better education on the type of care they're getting. They see testimonials, and we're now using this as a way to improve treatment outcomes for patients that are getting epidural injections. Now, I wanted to talk a little bit about the kinds of data that we've been acquiring and why we need to look into longitudinal data. So let's take a look at what we just did. Here we acquired data over the course of 2 weeks, which is arguably a short period of time. And we only have 2 data points. And I want to argue that that's actually not enough. Because if we had measured every single patient who received a treatment after an epidural injections, that's usually what their treatment trajectory looks like. So what you see here is their pain score and how it's varying over time. And you can see that within these first 2 weeks, a lot happens. And if I had asked them on one particular day, I would have seen a significant improvement where pain changes from almost 9 points to 2 points, which is massive. And on another day, I would have seen that there's no improvement at all. So just by measuring someone on a single day, we might not actually get the information that we want to. If we want to understand recovery, we need to start to track people over longer periods of time. So that means we not only need longitudinal data, but actually we need continuous data. And so the question is how we can do that. And I was very lucky that I could come to Brown and become part of the Brainstorm program because that allowed me to actually develop a smartphone app out of the lab. And so what the app is doing is it's actually tracking pain in patients. And here's an example of what this looks like. We're asking patients about their mood, their emotions, their stress, their fatigue. We track medications on a day-to-day basis. We track the treatments that they're getting and whether they engaged in certain activities, where in their body they were experiencing pain. And we could really range across the entire United States. So we have several thousand users. The age average is between 18 and 89 is our oldest patient currently, and the average age is 43. We won several awards just for the design of the app and the application, and we have more than 800,000 patient interactions since we released this. So you can actually download this from the Google Play Store and the Apple App Store. And if you wanted to use it as a researcher, this is a free research tool that you can use and run your own studies via the app. So if you're interested, just reach out to us. So what can we do with this kind of more fine-grained data on pain? Turns out we can actually now start to say, can we find out something about prognostic markers that are not only over the course of 2 weeks, but maybe an entire year? So here we ran a study at the Carnegie Institute where we are measuring 137 chronic pain patients. We measured a subset of them, included EEG measurements that I'm not going to show, but we use questionnaire-based data, the app, and then follow them up over the course of 1 year. And here's an example of what the data look like. And I think that is a striking example. So this is a chronic pain patient who doesn't show much improvement. This is someone with severe chronic pain. We're talking about an 8 or 9 point scale on a 10 point scale on average. And what you see, these little triangles at the bottom, that's actually the kinds of treatments this person has been receiving on a day-to-day basis. So this is data from 4 months. And what you see is that this person in particular is taking 3 different kinds of opioids, and on average, 6 to 10 different types of medications daily. And there's no improvement whatsoever in their symptoms. And what I'm showing you here is not an exception from the rule, it's actually the rule. And so now we can start to analyze what is really affecting pain dynamics and what's not. And why are people improving, and why are some people improving and others are not. And so what we do is we basically trained again a machine learning model to say, can we predict pain outcomes in the future? And one of the key predictors of future pain, which is interesting again, is expected future pain. Not only over the course of 2 weeks, but this time we're talking about the course of 4 months. So expectations play a huge role in the way pain develops. Another big predictor was depression. And that was very interesting because we know there's this very high comorbidity with depression. But the question is if it's bilateral. It's just chronic pain causing depression, depression is causing chronic pain. And we can now start to answer that question. And what we end up seeing is there's 2 groups, those with a comorbid depression. You see that there's almost no improvement over time. This is data from 12 months. And then there's a subset where people actually naturally improve when they don't have a comorbid depression. So there's a subgroup that we should really target who have a comorbid depression to actually improve their pain outcomes. Now, interestingly, while depression is predicting future pain, it turns out that pain does not predict future depression. In the same subset, there's other factors like catastrophizing anxiety and perceived stress that they're actually the key predictors of future depressive outcomes. And now this is data from 4 months, but we can do the same thing now with the app and say, what on a day-to-day basis, does that also mean that mood is not predicting pain, but mood is predicting pain, but pain is not predicting mood? And the answer is yes. So if you take day-to-day data, your future mood is predicted by previous mood, but future pain is predicted both by mood and pain. So it seems to be a very unilateral relationship where you actually have to think about what is this impact on mood on current pain. So where are we taking this right now? We've actually been turning this now into a digital intervention. So we're not just tracking pain anymore, but we actually use cognitive interventions that we deliver to patients in order to see if we can improve their symptoms, both at the level of mood, but also in terms of their pain outcomes. And the way we do this is that we've actually trained models to phenotype into different subsets of chronic pain patients, and those different phenotypes are receiving different therapies. And we're training an AI recommender that understands over time what is the best intervention for which person. A very simple way of understanding that is that in classical cognitive therapy, we usually don't know what the active ingredient of therapy is. But with this type of intervention, we can actually learn which of the interventions that you're taking leading to the best improvements in the short and long-term pain outcomes, and then over time, optimize therapy. And that's what we're trying to do next, and I'm quite excited and thankful for the amazing team that I'm allowed to work with. Thank you.
Okay, thank you.
Sure. Great. Thank you. That was fantastic. So there are a number of questions. How might different analytic approaches lead to different prognostic predictions?
Sorry, can you repeat that?
Yes, this person's asking, how might different analytic approaches lead to different prognostic predictions, different ways of analyzing?
Have you tried that?
Sorry?
Have you tried that?
Different analytic approaches in terms of different machine learning models?
I think that's embedded in the question.
Yes. In this case, we tried different models and they lead to the same outcomes, and but that's often what you can do. What we haven't done yet is, we used a regression where you basically look at the severity, but you could also look at classification and then subgroup into responder, no responder. We haven't done that analysis yet, but usually regression analysis are anyway more fine-grained.
How does your observation that a patient's expectation of pain predicts their future pain, what does that mean for pain patients, and how can they change their expectations of pain?
Yeah. I mean, I'm very interested in this role of expectation placebo effect in general, to be honest, because I think it's an undervalued and important outcome. So for the longest time, people have thought placebo is a mere psychological effect, whatever that may mean, where believing that you will get relief leads to relief. But it turns out it's actually a very biological effect. We now know for years that the placebo effect actually leads to endogenous opioid release in the brain that is affecting the ascending pain pathway. So it's a very biological response. It's just internal in the way the homeostatic regulation in the brain works. So because of that, I think that's why expectations matter a lot, because they actually lead to changes in the regulation of the system.
Yeah, I'll ask. Do you think that the effect of depression, I'm paraphrasing this, that someone with depression views the future more negatively, that is what the prediction is due to, rather than another aspect of depression?
Yeah, so one of the key aspects that people usually look at is catastrophizing, which is a key predictor of worse outcomes in chronic pain. And catastrophizing predicted depression, but not pain, interesting enough. But I do think that it is a more negative outlook. I think there's more to it. We're currently looking at the actual role of the corticostriatal circuit, specifically the interaction between prefrontal cortex and the basal ganglia, to understand what is really happening.
Okay, there is one last question to extend by 30 seconds. The case example you showed was pretty extreme in terms of the treatment received. Is that representative, or is that not representative of the wider sample?
Unfortunately, it's representative. What I showed is that a lot of those medications that we think, they take them every day, and they've been in pain for 10 years, and the average remains in 8. So I think that already tells a story by itself. But now we actually have the data sets where we really see that the impact of specifically medications is not as strong as we would like them to be.
Okay.
For treatments, it's a different story. For radiofrequency ablation, we see 2 different types of groups, some that do not respond at all, 3 types. Some that don't respond at all, some that respond very fast and the pain stays down, and some that respond and it shoots back up. And that's a very common thing that's observed.
All right. Well, we are out of time. I want to thank all of the speakers for keeping us to time.
Thanks to our audience. Great questions.
And thank you so much, everyone.
Birds. For the Diversity Research Award winners, the second place winners are co-first authors Eliana Boxerman and Madeline Rahili. Would you please come down and accept your award? Yep. Okay. And the first place winner is Christine Durkin. We'll do a little photo. Congratulations. Moving on to the undergraduate student award winner. The winner is Caroline Murray. Oh, yes, sorry. Oh, yes.
It went to the person that came up before. Yes.
We will do a switch. We're sorry about that. Okay. Moving on to graduate and medical student award winner. The winner is Benjamin Zaid. All right. Okay. We understand. We understand there are some conflicts. Thank you. And the research assistant and staff award winners for the second place, we have Samantha Chili.
Yes.
Okay, and the first place winner is Joyce Gao. And for clinical psychology resident award winners, the second place we have Rachel Kazicki. Yes. And the first place winner is Jessica Smith. All right, and for the postdoc award winners, in second place we have Destiny Prince Pereira. And in first place, we have Alexis Adams Clark. Not here, okay. And then finally, for the psychiatry resident award winner, we have Brandon Liu. And that concludes our Mind Brain Research Day. Thank you all so much for a wonderful afternoon, to Drs. Carpenter and Greenberg for leading this, and to all of our center presenters.